it was really exciting, and we thought it would be a really simple thing to do, but isn't quite as simple as the bright idea initially. So I'm going to talk you through the bright idea to the trials and tribulations, the final product, and what is of the future. You can access the app online, so I'll be able to give you the web address for that if you want it. You might have seen it already. Portsmouth is quite a large maternity service. Well, it is in the UK. We have over 6,000 births every year. We're really lucky in that we've got three freestanding midwifery-led units. The furthest away is about 23 miles, the nearest only being about 3 or 4 miles. And we've also got an alongside midwifery-led unit on the obstetric unit site. We have a home birth service, and our consultant-led labour ward is on the main site as well. We've been developing the service using a different model called the Nurture Programme, and the whole ethos of this model is that we must, as a priority, deliver one-to-one care, midwifery care to women in labour, which sounds really simple, but previously we really struggled to do that. In fact, when we did an audit in 2011, only 67% of women, particularly on the labour ward, were able to access a midwife in labour. So sometimes one midwife was looking after 2 women in labour. What that meant was that we had more low-risk women on our labour ward and not using all the facilities we had, and it was a little bit chaotic. And in fact, in that year, only 10.9% of births were out of hospital. Then the Birthplace research came out, and that was like the icing on the cake for us, because
I'm sure there's nobody in there, Pam. You can.
Hello. So there was Birthplace came out, and we thought that was useful in terms of helping our women and our midwives to think about the evidence, so they could start planning on giving birth away from the main obstetric unit. So just we had loads of women just turning up in labour without any thought of where they could give birth. And I'm not going to go through all the Birthplace research, but it was quite clear that, number one, that giving birth is generally very safe, and midwifery-led units and all the evidence they had was safe for the baby, but offered some real benefits in terms of outcomes for the mother. And since Birthplace research, the NICE guidance has been produced, which I think, again, is really helpful in getting that information over to midwives and women and the planning of maternity services. So Birthplace came out, and we ended up with really too many questions. How are we going to increase the number of women expressing a preference for place of birth? What opportunities could we give them rather than just turning up in labour? How did we give the information to the women about their choices? They get so much written information during pregnancy, and the information about places of birth in our trust were lost in the sea of all the other bits of information that they have. We also realised, in talking to mothers and midwives, that they really struggled to understand the Birthplace research. They found it difficult to understand, and therefore, particularly midwives were then not passing on simple messages to mothers to help them make choices of place of birth. We had loads of questions about how would we design something that was useful to women. Was it a new leaflet? Was it a video? Was it something just on our website? We weren't really clear, and we started to ask women what would they want to use. Now, obviously, we realised that nearly everybody had a smartphone or access to computers. We have access to computers on maternity centres. We've got iPads in the maternity centres. So we thought that probably going down the app route was the best way. We also realised that, and I think this is very common, that even though a midwife and a mother might have a very in-depth conversation about the evidence for, say, choosing place of birth, but they are very quickly influenced by other people. So their mothers, their next door neighbour, their sister, their partner. So even though they leave the meeting with the midwife understanding the evidence and thinking they're going to choose a home birth or a midwifery-led unit, they are very easily influenced by people who don't have access to the same information. So we really wanted to have something that was easily accessible to others and not just the women that in their appointment with the midwife. And we also wanted to look at how we portrayed this information in an informed shared decision-making way, rather than just giving women informed choice and expecting them to go away and make that choice without any support. So the shared decision about the professional discussion between the midwife and the woman, taking the preferences of the woman and the advice of the midwife into account. So that was a big part of the project as well. It wasn't just developing an app. We were really lucky in that we applied for a Health Foundation Shine Award, and we were awarded just under £80,000. We couldn't have been more shocked to have been awarded the money, and we were delighted. It gave us the opportunity then to put together some really clear objectives. We realised quite quickly on that we would be developing a web application that could be accessible on all computers, smartphones and tablets, that we would provide the shared decision-making tool for prospective parents and midwives that was based on the Birthplace research, so giving that unbiased information. We would look at the national data, but also adding into it our local data so that women could see, for example, the transfer information in Birthplace was different from our own transfer information, and we wanted to make sure that women understood that there was a difference, and actually we transfer much less from our midwifery-led units than the Birthplace research did. We wanted to make sure that we could enable parents to consider their thoughts and feelings around place of birth, so that the pathway in which the app was used it allowed for more conversation about place of birth than we previously allowed for in our maternity care. And then finally, we needed something that was simple, that would provide a summary of all the key information about women's preferred place of birth, and we use preferred rather than choice really carefully, and we've had lots of conversations about that. The app wasn't about saying to women, we're helping you choose, and once you made that choice you can't move from that choice. It was about them understanding their preferred place of birth, and the choice is not actually made until they're in labour, they've spoken to the midwife, and the choice is made based on the current status within the service and what's going on with the mother. And that language has certainly helped have different conversations with women, particularly around women who feel they've chosen a place of birth and then that cannot happen for whatever reason, either something's happened with them or something's happened in the service, and then feeling disappointed. So preference was a really useful way of putting across this whole project. The process after the Shine Award, and I think this is probably one of the things I would say in terms of if anybody is going to be doing something like this, whether it's setting up a web-based app or any sort of online tool, is you really need to get the right people in the room at the beginning. You need to set up a formal steering group, have all of the varied views, knowledge, experience in one room. What we found was really important as well was appointing a project manager, somebody she wasn't a midwife, and actually that was really helpful because she project managed. She didn't get involved in her thoughts and views about what the content was going to be, and she mobilised everybody to do what they should have done in time, and that was really, really helpful. We had a technical designer, again really important, somebody who understands how to build the data behind the app. And in fact, we had somebody who was a professor of technology in a university who was really keen to be involved. Obviously, working with women to develop the tool was really important, and that was one of the things we did wrong. We didn't involve them early enough. We appointed midwife leads, so the question about how do you get this out to the midwives' attention so they start using it. So we appointed midwives who would be doing that in their peer group. You have to know whether it works, so you need an audit tool, and that's really important. The audit tool and the survey information and focus group information needs to be designed right at the beginning, so you start collecting data straight away. We then identified a pilot cohort of women, we trained the midwives, and we got it all going, and then we did an evaluation. All the way through this, we had to think of ways of making the app appealing. So enhancing the graphics all the way through the project became one of the major parts of it. We kept changing it all the time, and in fact we still are. And then finally, the process as part of the Shine Award was about spread. How are we going to get it out there? How are we going to make sure everybody was using it locally? Was there an opportunity regionally, nationally, and potentially the world? And how were we then going to market it going forward? So getting the right people involved, as I said, the project lead is quite important. So somebody in a position of influence. So I was the lead on the project, which was really key. So I could be saying to all of the midwives, you must use this. Once we were rolling out, this wasn't an option. This wasn't a choice option for them. It became part of the pathway. A dedicated project manager, I've already said, really, really important, because it's complicated to do a project like this. It isn't as simple as you originally think. Having somebody who is representing women is really key. So somebody who has the time to come to all the meetings, who can go back and talk to women and bring their views back consistently to the meetings. That you also have midwifery clinical experts. We had midwives, student midwives and consultant midwife on the project. And again, really important. Now, one of the things about having lots of clinical experts in the room is they all have different views and different ideas. And that's really valuable, but sometimes can take the whole project off course. And we had to work quite a lot in the background to get a consensus on some of the things that we were doing within the project. We had a researcher as part of the group, because we managed to then get some money at the end of the project for somebody to go forward and test it all under a PhD. Technical experts definitely have finance involved, because it costs much more than you ever think, and you need to keep an eye on that, and obviously the midwife training leads. We had a clear project for the framework, and because it was part of Shine, there was quite a complex reporting schedule as part of that, but it also needed to sit very clearly within the trust governance framework, so that we didn't do anything dangerous, because ultimately the trust is accountable for anything it develops. So the Birthplace steering group linked into the governance framework within the service, and it was all the actions and current issues were reported through that, and also we kept a really clear risk log as well. We had very clear subgroups, and that again, advice to anybody who might be doing this sort of thing: don't just expect one group of people to do everything. It gets too complicated, and we did start doing that, and we realised fairly quickly that we needed to set up all the subgroups that had different people on it, so that their attention could be just on that part of the project. So the system specification subgroup had the technical advisor on there and the clinicians and the woman's rep, and that was really about what was it going to look like, what was the technical data behind it, what were the graphics behind it. We had a communication subgroup, again a really important group, because we had to get the message about the app out into the community. So that was to the staff, to the women, through local media, a media launch. And again, we had our comms expert for the trust on that group, and she helped us get the launch through local BBC programmes, the local paper, local radio, and that was really important to be able to get it out to a wide reach within the community. Obviously, because it was a Shine award, we had to collect data and analyse that data, and again we needed a separate group with the expertise to do that. We had another group looking at, with the midwife leads, looking at how we're going to implement it and how we're going to train the midwives, particularly around the shared decision-making pathway. And then we had a final group, and because of the Shine again, we had to then pull all of this together and write a final report, which had to be comprehensive. So we needed somebody else focusing on that. That group also started to write things for publication, and indeed they've had an article in the RCM journal, and also they've submitted something for the HSJ. All the time underpinning all of the project is about spread and marketing, and again, we were late starting that and realised unless you're going to have something that's going to make an impact, if it's good enough it needs to make an impact, you have to talk about and think about how you're going to spread the idea and market it all the way through the project, and plan that for the end of it as well. So the app itself, the conception to the birth was a very long labour, and we had no idea that it would take so long. Those of us that were involved in the first steering group are midwives. One person was a nurse and a midwife. She's our head of research, and we came up with something really simple, and it was on PowerPoint, and it just said, "Are you having your first baby? Yes or no?" And we hoped that somebody would design the working of it. You pressed yes, and then it just gives you the birthplace data. The final product, which we are revising all the time, it was much more complicated than that, and all the screens are open in different ways. There's different ways around the app, just like any other app really, and it certainly was much more complicated than we had originally anticipated. And I think, going back to what I said before, getting technical designers and graphic designers involved at the beginning is really, really important, because when you have a bright idea and you're a group of midwives, the difference between how you think an app runs and all the apps you have on your phone, and when you look at things on computers, the workings behind it are much more complicated than we had ever envisaged. So, developing the app. The first design, the ideas were very basic, and I think the big thing about that is never underestimate how complicated it's going to be. The first big lesson really is ask the end user early. Don't, whatever you do, think you know what they want, and we made that mistake. We had conversations with users, but we certainly had some very clear professional views about what we wanted, and when we started to test it with focus groups of women, we were completely wrong. We were definitely making it much more complicated. So, for example, we put percentages in because that's what's in the birthplace data, and a lot of the women didn't understand percentage. And if you look at the app, you'll see it'll say 10 out of 100 rather than 10%. It might have the percentages as well, because obviously some people do understand percentages, but we realised really quickly that they absolutely did not understand what that percentage looked like. Also, when it came to demonstrating the data, we used pie charts. We tested lots of different ways: graphs, pie charts, little people on a sea of people, and the pie charts were the simplest thing for them to understand, and they said that made loads of sense to them, and that's why we went with that. The focus groups of women continually reshape the information all the way through the project, and we're still doing that. So all the revisions that we have, we'll test with women so that we have really simple representation. The other thing that they wanted, which we hadn't thought of, they wanted it linked to other information. We already had videos on our website of hospital tours and parent education type information, and they wanted that all linked into the app, so it was a one place to access all that information. Lots of the women, and particularly the midwives, also said that they were interested in the original research, so we embedded that into the app as well. In some of our evaluation, the midwives said that they found that really valuable, because once they worked through the app, they then realised that some women wanted to know more, and they could easily show them how to access the original research. The graphics are important. We started off with no graphics. We tested it and piloted with really simple graphics. What the women find attractive about it is the way that it is now, and it makes them want to open it. And they were really clear about that. We didn't think in the beginning that graphics were important. We thought the information was more important, and we were wrong. So having a good graphic designer, or somebody who can do both the web development and the graphics is really helpful, is really important. The other thing about, if you're doing it in-house in a hospital, involve your own internal IT services early, because if you're going to have it as a web-based app, it needs to be integrated into your hospital website, and there were some glitches around that because we started with them too late, and there were things that needed to be changed. And the other thing, I think, certainly from me as a midwife, I didn't really understand the difference between web-based applications and apps that are available in app stores that are specific for devices. And actually, having a web app means, especially if it's something that needs to be constantly changed and upgraded, it is easier to do that. But of course, that website needs to be hosted, and there is a cost to that. So going to the pilot itself, we had 30 midwives who received training in July 2013. We had a target of 250 women to be in our pilot. In the end, 236 women were recruited, and they were given the access to the app with a leaflet which had the QR code on it. Now we use just little cards, and we're just moving to stickers that go on the note that just have my birthplace and then the QR code, so they can scan it into their phones. And there's also the website that they can access direct onto a computer. At the time, we had digital pens here, and we started a digital pen form to collect the information that automatically was uploaded into the project databases, so we could collect the information about the women from the first time that they started to use the app. Of the women that originally were given access to the app, 167 went on to have their babies in October and November, which was the months that we were collecting the data. Which was slightly lower than we thought, but in fact some had moved out of area and some delivered outside of the months. So the outcomes, we did a data analysis, which was really important. I'll talk about that in a minute. The personal feedback from the women from interviews and focus groups was really important, and that is certainly the thing that's helping us revise the app going forward. The things around what it looked like was really important. You know, the graphics were important. That absolutely came back from the mothers. They also welcomed the discussion with their midwife throughout the maternity pathway about their preference for place of birth, and they felt that was really helpful. Personal feedback from the midwives came from focus groups. Again, I would say most of them liked it. There were some, and this is the downside of it, felt they didn't have time to give the information to women about accessing the app, particularly if the women then struggled to access it. And they also had some concern about the shared decision-making pathway and that increased their time in their clinics. We've thought about that quite a lot, and we're now in the process of reviewing our antenatal pathway and the information we give women and when, so that we can have more time for this really, really important discussion about preference for place of birth. And the app itself, the original design had a survey embedded in it, so women could fill out that survey when they downloaded the app, and then they could email it, automatically emailed that information back to us so that we could analyse it. So I suppose really the most important outcome for us was, did that group of women think about their preference for place of birth? We already knew anecdotally that women were turning up in labour in the hospital without any thought of where they might have their baby. So what we looked at is where we'd recorded their preference for place of birth at 12 weeks and then how it changed at 36 weeks in the pilot group. And thankfully it shows that women were expressing quite a clear preference by 36 weeks, having gone through the pathway and worked with through the app with their family, their friends, their partner and everybody else. The most surprising thing for us, and we're really pleased about it, that instead of just they wanted to be in hospital, but their understanding of what was offered in our alongside midwifery-led unit was much clearer, and 90% of that group made a very clear preference and informed choice of being in the alongside midwifery-led unit, which I think is really good. You'll see the percentages don't add up, and that's because some people made more than one choice. There were less people undecided at 36 weeks about preference of place of birth, and that was really helpful for us. I just put in this picture. This is our graphic designer helping us design the final graphics, and those meetings were really essential to make sure that we got it right. And again, everybody's opinion about what colour it should be and what logo should have, it was incredible, and in fact was probably longer than some of the discussions about how we were going to present the data. I've just put some feedback. We had lots of feedback. Most of it was positive. This was just some midwife feedback who was really excited about it, and felt that in her own caseload that women had a real lack of knowledge about choices of place of birth, even though in this service we offer quite a lot of choice, and it wasn't one of those things that was well discussed with women. And certainly she really believes it's made a difference, and lots of midwives have said it's made a difference now in the terms of conversations with women about preference for place of birth. And we do know, and we're just about to do another audit, but we do know that when women phone up in labour now, when we say, what was your preference difference for place of birth, they are able to tell us. So in terms of the rollout, that is definitely making a difference. The other thing that we think is making a difference, but it's not long enough yet for us to audit, is that we now have about 25% of women giving birth off our labour ward, which is really good, and that is having an impact on some of our outcomes. And I know this is just statistical data, it's not research data, but in November our normal birth rate was 70%, which was the highest we've ever had. And I'd like to think that that was not just because of the app, it will be about our model, but our app is certainly helping women making decisions about where they have their babies. Good practice that we would share with others is, just in summary really, absolutely imperative. Don't even think about doing anything like this unless you work with the end user. So if your end user is women, make sure you've got a reasonable access to women right at the start to get their views and record their views. If it's midwives, if it's something for midwives or other health professionals, get them in right at the beginning. If it's a proper project, and I would suggest that if you're not going to waste time or money, get a proper project in place, get the right people in place early and make it absolutely clear what their roles are. Certainly having a project manager was really important for us. And also the clinical leads working out in practice with the midwives to make sure that everybody understood the app and how it was going to be used. Make sure you cost in all the expert time that is required. We certainly forgot about costing in ourselves, some of the midwife support, and some of that time can be very expensive. So if somebody wants to replicate the project and you haven't costed the whole thing, it's then really difficult to say how much did this actually cost to develop. Make sure that you give time to training of staff that are involved in the project, because without the training, and each midwife, they had about 2 hours each, the whole thing about the shared decision-making pathway would have been completely lost. The other thing to think about is once you've developed it, you then have other views about what to do next. So always plan the future with regular revisions, and then keep refreshing everybody's use of that with a relaunch. And we're in the process of doing that at the moment. And finally, I suppose if you're going to do anything like this, trademark it. We had that advice from the NHS Innovation Department.